So we're moving on to our next topic. There are many questions floating around in hospital cardiac arrest. What is the incidence compared to out-of-hospital cardiac arrest? Etiology, mechanisms, are they the same? Do we have a proper system to recognize it while we are in hospital? And how can we prevent it? All these questions or issues will be discussed in our next talk titled In-Hospital Cardiac Arrest, a Preventable Event. I have the pleasure to reintroduce to you our next speaker. He's a professor of medicine and a professor of physiology and biophysics at the Rosalind Franklin University. He obtained his MD degree and internal medicine residency training at the University of Chile. He's also the director of the Resuscitation Institute at the same university. He has served as a member of the BLS, ACLS subcommittees for the American Heart Associations. He has more than 180 publications and received multiple awards. Please welcome with me Professor Raul Gazmuri.
So that was a preventable event. So now we're back in business. And I hope to convince you that we have tremendous responsibility and the option to be successful in terms of reducing the incidence of in-hospital cardiac arrest. And to give you some numbers, these come from the American Heart Association and an effort to get some numbers. We now think that there are approximated in the United States, and I don't have statistics from other countries, close to 210,000 cases of in-hospital cardiac arrest. The survival of this episode is around 24%. For adults, it's about 23.9%, and pediatrics is 40.2%. Now, if we looked at the mechanism of the arrest, we will learn that only about 17.6% of patients of all ages, the mechanism of the arrest is ventricular fibrillation or ventricular tachycardia. Now, if we remember out-of-hospital cardiac arrest, the numbers are about double, close to 400,000. And in those cases, the episode is a sudden event and usually primary cardiac in nature, in which VF and VT have a higher incidence. So in the hospital, VF-VT is lower incidence. Now, I'm going to show you some of the studies looking at patients who had a cardiac arrest in the hospital. And it turns out that many of them have abnormalities that preceded the event. And as I'm going to show you in a minute, those abnormalities often lasted hours, if not days, before the event. And patients who had an episode of cardiac arrest more often had respiratory abnormalities, abnormalities that relate to the cardiovascular system that can be detected. So I'm going to make the case later that if we pick up on these abnormalities and if we intervene early on, we might be able to prevent the progression from what we call clinical deterioration to an episode of cardiac arrest, which most of the time is not primarily cardiac. Back in 2006, there was a very useful publication. It was the first consensus conference on medical emergency teams. And I have followed up this group. I have not seen the second consensus conference, but I think the first one was very useful because it lays out the ground of what happens in the hospital and gives us a way forward how to prevent these episodes. Now, one important concept that is important to remember is that these episodes very rarely are abrupt. And there's a progression, clinical deterioration, leading to cardiac arrest. So the framework that is proposed and the one that we have implemented in our hospital, and the one I'm going to show you later, is the following. First of all, it's very important that we are able to identify the event of clinical deterioration as early as possible. And the moment that we recognize that we trigger the alarm. That is what is called the recognition limb, or the afferent limb of the system. Once the recognition takes place, then the hospital will activate the resources that are appropriate to the event. And I have a few acronyms: MET, Medical Emergency Teams. We have RRT, Rapid Response Team, and another term, CCO, Critical Care Outreach. They all have in common that they're ready to react, and that is the efferent limb, the response arm. And it has different characteristics in different places. That also includes the cardiac arrest team. And it's very important to get support from your administrators and to have data that will allow you to look at the system and see how it impacts the incidence of cardiac arrest. What was very helpful in the process was to have the Joint Commission in the United States recognize that this was a very important enterprise. And just to tell you just a little bit without going through this lengthy document, the Joint Commission recognizes that hospitals should have a system to identify when a patient deteriorates. Part of the process was to have the system that recognize deterioration in some form of warning signs that are written, that everybody knows, and that enables anybody, not only healthcare personnel, but also patients as well as relatives and friends, to activate the system. The idea is to have a very low threshold for activation of the system. And many organizations have currently endorsed the practice of having a rapid response system. And in fact, if you go to practically any hospital today in the United States, you're going to find that there is some form of a rapid response system. Now, it's true that very early on, when the data was analyzed in terms of impact, it was not very clear. There was this assumption that, in fact, we are not actually impacting the final outcome. We're recognizing early on patients who are deteriorating, moving them to intensive care, and then eventually they die, so there was no overall impact. At the same time, the people who were working on this hospital realized that that cannot be the case, because many of the conditions that leads to the event are clearly preventable. A patient in respiratory failure, if the failure is treated early on, it's easy to understand how that adverse event can be prevented. In fact, the most recent data support the practice, and there's no longer discussion as to whether or not we should do it. I think we have to do it, and the question is, how do we do it in a more effective manner? And this is just one example of a more recent study showing a reduction in the incidence of cardiac arrest from 4.67 per 1,000 admission to 2.91 per 1,000 admission in one hospital after a rapid response system was implemented. Now I'm going to tell you how is that we have done it in our hospital. And maybe this is a good example because we have done it in a different way. We have used the resources that we currently have. We did not develop a separate medical emergency team. We used the people who work in intensive care. And part of the reason why we did that is because at the end, we are the one, I'm an intensivist, so I am the one who is going to take care of the patient who suffered an episode of cardiac arrest in the hospital. That patient is going to come to ICU if there is initial return of circulation. So by looking at those patients, we realized there was plenty of opportunity, most of them, to intervene earlier. Therefore, many years ago, we developed a system that is run from the intensive care unit, and I'm going to briefly describe that. I know that's a busy slide. I put it there for one reason. At the very top of our algorithm, there's a number that's very familiar to us, which is the 911, which is used in the United States to activate the emergency system for a cardiac arrest outside the hospital. We're using the same number inside the hospital, and we merge the code team and the response for clinical deterioration. So we have trained our dispatchers to ask the first question, is the patient responsive or not? If the patient is responsive, by definition, that patient is not in cardiac arrest. And from that point downward, the call often ends in the ICU if the call was for clinical deterioration. And I'm going to show you what happened next. Now, if the patient is unresponsive, we stop asking questions. We presume that that patient could be in cardiac arrest, and we activate the call team. No question asked, we just run to the place. Whether or not the patient is in cardiac arrest at that time, it doesn't matter. We want to be there as soon as possible. And we are not concerned about having a relatively high incidence of what we call non-cardiac arrest codes. That's okay. It helps the team as a training tool, but we don't want to waste time. If the patient is responsive, there's time to ask questions. Now, in terms of what would trigger an activation of the system, if you read the literature, you're going to find many combination of of warning signs. One commonly used system is called the MUSE. It's a modified early warning system. What you see there, without going into details, is there is a scale in which points are added based on the abnormalities. And that works for those who use it. We thought to keep it as simple as possible. And instead of asking healthcare providers to add points, we just want them to recognize one warning sign that is abnormal and call us. Because in our system, we are not going to deploy a team if it's not necessary. So we want to keep the threshold for activation very low, and we just want you to call us if any of those conditions are met. And just to give you a few examples, a respiratory rate that is too low, the patient might be overdosed with analgesic opiates, or it's very high. Very common for the patient to develop respiratory problems that manifest initially for tachypnea. And oxygen desaturation. If somebody realizes the patient is using respiratory accessory muscle, that means that there's an increase in the work of breathing. We want to know, and so forth. We also included in one of our latest iteration a patient who has repetitive episode of seizures, a patient who has altered mental status, and a patient with chest pain. We want to know about those patients. Now, it's very simple. This is the booth. We call it our RRS booth. What you see there, a computer, a red phone, and that's true. We selected a phone that is red and had a very distinctive old ring that the nurses recognize immediately, and our nurses are going to pick up the phone typically before the third ring. And as soon as the phone rings, the ICU nurse picks up the phone, will gather information based on a list of questions that we have already scripted, and inform the resident who is next to the nurse there what's going on with the patient. And very often we're going to send the resident alone to go and assess the patient. Now, based on the information that is being provided after the phone call, then the action will follow. Now, in our hospital, we have buildings that are outside the main hospital. For example, mental health is a building that is remote. So in that instance, we will not send our resident, but we will manage to bring that patient to be evaluated, if we feel it's necessary, to the emergency department. So for us, for our rapid response system, the emergency department plays a very important role, because the emergency department will assess those patients and then make a determination of what to do next. We believe, and I'm going to show you very soon, that going to assess the patient might not be necessary and may not be useful, because we have learned in the process that often the patient needs to be moved to a higher level of care. So it really wouldn't make much sense to implement care for a patient who actually needs to be in a different location. Now, the other thing which is important to remember, the rapid response is not an activation of a code. It's only the recognition of physiological deterioration that enables us to act earlier. But in the process, we have the option to convert that call into a code. And we quantitated that. It happens probably in anywhere between 1 and 2% a year, in which the nurse, as she or he interacts with the caller, realizes the patient is deteriorating. And at that point, instead of sending the resident, we'll activate the code team. Now, this is some of our own statistics. You can see there that if all the code that we analyzed a few years back, RTW means return to the word of origin. So the patient came to the ED, for example, it was sent back to the same place because it was deemed to be stable, not requiring. But in the other two situations, the patient was admitted to medical surgical unit or went to the ICU. So roughly 2/3 of the patients, in our experience, will be moved to a high level of care. We also noticed that there was an important reduction in the percentage of patients who had a cardiac arrest outside the ICU. And that was the primary intent. We moved the patient to a monitor bed, typically in the ICU, before they have a cardiac arrest. So it was expected that there would be a reduction in the percentage of patients having a cardiac arrest outside the ICU. The few instances in which patients had a cardiac arrest in the past, it turns out that there were signs of clinical deterioration that we missed. And there is statistics there showing the sign that we as a hospital missed to react on, and typically respiratory rate was very high on our list. I'm going to skip that slide because of time. I want to show you something that we have done more recently and go back to the statistics. So we learned that we are effective now. We can recognize clinical deterioration. We have a system to act. We have significantly cut down in the number of cardiac arrests. We will admit the patient to a high level of care early on. And we ask the question, could it be that we could identify those patients who are at a higher risk of activation of the system at the time in which they come to the hospital? Because just by looking at the patient, we realize that most of the patients in whom the rapid response system was activated were patients with multiple comorbidities and some sort of acute illnesses. And most of that information often is available at the time of admission. So with one of our medical students, we designed this study. We came up with 50 variables that we thought could be useful in predicting subsequent rapid response system activation. And this medical student did a very nice job, and she analyzed 1,581 admissions to medical surgical unit over 1 year period. And there were 38 patients who activated our rapid response system and 1,543 who did not. So we compare those patient population to identify which factors were predictive of. Now, just to give you a brief idea, these are the conditions, the warning signs that were more often used for activation. And you can see in blue those who belong to the respiratory system, and in red those that belong to the cardiovascular system. And we have learned that over and over again. The clinical deterioration is typically because of a respiratory event or a cardiovascular event that lingered for hours. That's an important concept. There's plenty of time to identify and intervene. And you can see here that the time from the moment of admission to RRS activation varies. Close to 80% will occur between the first and between 6 and 12 days, as you can see in that statistics. Now these are, it's a busy table, but those are the variables that were statistically significant based on univariate analysis. Now that doesn't help a lot, so we took those variables and entered them into a multivariate analysis. And this is what is shown in the next slide. And these are the clinical variables that were associated with significantly with a higher risk of subsequent RRS activation. One, if the patient had been admitted to the medical surgical unit from any other place in the hospital. If the patient had previously activated the rapid response system. If the patient had a cardiac arrest, tachycardia with a heart rate of more than 100 beats per minute or 100. If the patient has tachypnea, if the patient has a history of tobacco use, if there was a history of atrial fibrillation, or a history of syncope. All those variables, if present, had an independent predictive effect. And when we did the ROC curve, we found that it was statistically significant. At the moment, we are in the process of validating that score in a separate cohort. And I can tell you, I don't have the data here, but indeed, there is validation of this scoring system. So we believe that there is a possibility to risk stratify patient early on. Now, if you're able to do that, what means that once the patient is in the hospital, you can say, this patient have a higher risk than this other one, and you might be able to mobilize resources in a more effective manner. So to finish my talk, what I wanted to tell you today is that we have a problem. Houston, we have a problem. I heard that before. But it's a problem that we can solve. So around 210,000 cases of in-hospital cardiac arrest occur in the United States. Most of the cardiac arrests, and the statistics report close to 2/3, occur gradually preceded, not gradually the event, but preceded by gradually clinical or physiological deterioration over hours and sometimes days. The rapid response system concept can recognize those patients early on and act in a way that it can prevent the progression to cardiac arrest. So without negating the benefit of CPR when the event occurs, the clinical profile of in-hospital cardiac arrest points to prevention by early recognition and treatment of clinical deterioration as the most impactful intervention. And let me make just one brief comment. Having worked at the American Heart Association, there's a lot of emphasis in looking at the outcome after an episode of in-hospital cardiac arrest. And on average, it's about 24% survival. But I think we should be working not on the numerator, but the denominator, and reduce the number of events. I think that is the most effective way to act. And I know it's difficult to measure that because the denominator for in-hospital cardiac arrest is an elusive one. Some people look at the number of admissions, others at the number of discharges. It's difficult, but I think that is where we should aim our effort, the prevention of in-hospital cardiac arrest. Thank you.